we will continue with our presentations on abdominal imaging topics. And today, Dr. Dunya will talk to us about the radiological features of and grading of liver and splenic injuries. It's a very important topic because these are emergency. So you don't have time to call someone or consult someone. Liver and splenic lacerations are emergency topics. So we need to take good care about it. And although it's a little bit long, but I tell you, she did a very nice job. So focus, please.
Okay, so our topic is about radiological features and grading of liver and splenic injuries. So I will split it in two halves. First, I will talk about the liver injuries, and when we say grading, it means CT scan. Okay, and then I will cover the splenic injuries and the radiologic features and grading of splenic injuries. Okay, so as an overview for the anatomy of the liver, we know as an external morphology is divided into the right lobe by the falciparum ligament, divided into right lobe and left lobe, and then by the we have the H ligament and the porta heparis in the center, which is a you can see caudate and the quadrate lobes, which is better visualized on the inferior surface of the liver. And as we mentioned, there's this area of the porta heparis for the exit of the bowel duct and the entrance of the hepatic atrium portal vein. But based on the functional not on the anatomy, and also based on the biliary drainage and the vascular inflow and outflow, we can subdivide into the 8 segments, okay, by the help of the hepatic veins. So the right hepatic veins divided into the anterior and the posterior segments, and then we have the middle hepatic vein divided into right and left hemiliver. And then we have the left hepatic vein, which divides the left lobe into the medial left lobe and the lateral part of the left lobe. And of course, on the transverse plane, we could see the portal vein that divides into upper portion and the lower portions. So let's go to our subject about liver trauma. We know that of course the most common is the spleen, but after that, second to that is the liver, is the second most common injured organ. And if you ask ourselves why is that, well, because first of all, it's the largest solid organ in the abdomen, so it's liable or prone to injury, and also it has a thin capsule and friable parenchyma. Of course, it's fixed in position by the aid of the ligaments, so that will all increase the likelihood to get injured. And in general, when we talk about the mechanisms or trauma, of course, we know that we have blunt trauma and abdominal trauma. Blunt, for example, like motor vehicle accidents and penetrating gunshot wounds or stabbings, and of course it could be also iatrogenic related, either when you do colonoscopy or in the hepatic flexure, or when you do the percutaneous liver biopsy. These are all could be as a cause of for the liver trauma. And so we say that it's the second most common cause, and it's regarded as a 20 to 30% of overall blunt abdominal trauma will include the liver trauma, and usually they carry a high significant mortality rate. And of course, size-wise, the right lobe is bigger, so it's more. It makes sense that it's 4 times more frequent than to get injury than the left region. And also, it's also one of the reasons why it carries significant mortality rate, because it's over 50% of those hepatic injury cases are accompanied with the other intra-abdominal organ injuries. For example, when you have a left lobe injury, like 45% of them, they have also splenic trauma or pancreatic trauma, or if it was a right lobe involved, sorry, this is right lobe. Right lobe involved, we can see the 33% will be associated with the rib fractures or adrenal injuries, and other organs, also, of course, like lungs, may have hemothorax or pneumothorax, or the spine, like the transverse processes, or kidney. Okay, so
So the lesson here is whenever you have one injury, never stop looking for other injuries.
yes, you shouldn't stop.
Not only liver injury, okay, liver injury, that's it. Check the spleen, check the pancreas, check the lung, check the rib, check the vertebra, check everything, okay?
Yes.
The injuries doesn't happen in isolation.
And of course, in order to radiological aspect, for detection and also to characterize the injury, of course, the best modality of choice is the contrast enhanced CT scan, we have a criteria which was published by the AAST, which is abbreviation for American Association for the Surgery of Trauma. That was most recently revised in 2018. And so they simply put a guideline, and they divided the liver injury into grades from 1 to 5. We will also cover the splenic. Also, they are also 1 to 5. So, but before going or diving into what are the grades of AST for the liver injury, when we look at let's see what are the CT features when you look at the hepatic injury. Of course, we could have intraparenchymal laceration. Intraparenchymal laceration is on contrast in CT scan. It's seen as a hypodense or hypoattenuation area, either as a linear or as a stellate-like shaped, and it's multiple laceration on the liver. We can see, of course, the rest of the normal liver parenchyma is homogeneous. It should be like that on contrast enhanced CT scan. But here, because this hypoattenuation, so this indicates that there is a laceration or damage to the liver, right? So, and also we have a term, pure claw. It's a term that's used when we have multiple radiating lacerations, okay? So what are the other features we can find on the CT scan? We can also find subcapsular hematoma, and again, this is also this area appears as an area of low hypoattenuation or hypodensity, which is between the liver and between the capsule. You see, as the name implies, subcapsular hematoma. And also one thing that to distinguish it from the intraperitoneal hemorrhage, or let's say bleeding, is that it distorts the underlying liver tissue, okay? Or let's say indents, okay? And also we can see multiple subcapsular hematoma, and this is intraparenchymal hematoma, okay? Yes, as it has a mass effect. Yeah.
And then it's the surface of the liver.
Yes. So it can be different from free intraperitoneal hematoma, is that it causes indentation or flattening of the underlying liver margin, despite the hepatic hepatic architecture. So this is a coronal section. We can see again area of hypodensity. It's subcapsular hematoma, which is between the liver capsule and between the liver parenchyma, and it looks like a pressure effect on the underlying liver. Okay, so what other additional features we can see on the CT scan? Of course, we can see intraparenchymal hematoma. Look, it's an area of hypodensity with ill-defined usually. Usually, we will investigate by the contrast enhanced CT scan, but if we do it like a native CT scan, it will hyperdense. But most likely, we see this hypodense area, and we can see also there is an area of low density around the liver, which it's indicate that there is also hemoperitoneum.
So, just wait. Keep the column, the last one. No.
Yeah, this one.
Okay, no problem. The intraparenchymal hematoma is, of course, associated with laceration.
Yes.
There's a laceration, it bleeds, makes a hematoma. So the density of the hematoma will vary according to the age of the bleeding.
Yes.
If it is long-standing, it's been like few days, it will be like the first image, hypodense. If it's recent, fresh clot, it will be the second image, which is dense. In addition, if it's without contrast, it's more likely to be dense. If it is with contrast, it's more likely to be hypodense. And of course, with multiple abdominal injuries, the patient is an emergency. You don't have to do urea and creatinine and adenoma. So you go for native CT first. And then when you finish the urea and creatinine and then creatinine clearance and adenoma, the whole thing, then you go for the contrast CT. So probably it will be dense at the beginning.
Yes. Of course, we can see this in native CT scan. There is no we can see there is no contrast media like inside the aorta, and this is that there's like tree-like branch within the liver. This is we can see that there is a contrast-filled vasculature of the liver. Okay, so moving on to another feature we can see as a acute hematoma or active bleeding. This, of course, it's contrast enhanced CT scan. It can be seen as that there is a extravasation of the contrast media. Where is it? It's in the liver contrast material extravasation. So we can see that it's like either as a focal or diffuse collection of the contrast medium within the liver parenchyma. Of course, this is because of this area of hypodensity, and within the liver parenchyma, you can see this area of hyperdensity. So what is it? This is the spillage of the contrast. So this area of hyperdensity, this indicates active bleeding or acute bleeding, acute hemorrhage. Why? So within this hypodense area, okay. So other features, of course, we could get like even the hematoma extending to the major hepatic veins, like middle, right, left basement, and also or to the inferior vena cava. For example, this we can see area of devascularization devoid of not enhanced by the contrast media. So this indicates that there is a cut of blood supply. This is due to the right hepatic venous drainage have been damaged. Okay, and even the laceration could extend to the inferior vena cava.
So in fact, it's not cut off blood supply.
Yeah.
It's cut off hepatic drainage or venous drainage.
Okay, yes.
The blood is coming, it's not going out.
Yes.
Okay.
And of course, we could get bile duct injury, especially around the porta hepatis. And one of the reasons, one of the causes is it could be related to the during laparoscopic cholecystectomy. So we could get bile duct injury, and of course we could get vascular injuries in the form of atriovenous fistula or pseudoaneurysm. And one of the ways to differentiate from the active bleeding, or when you say there's extravasation of contrast media, is that we see that there is a river of contrast media, and will increase in size, like when you follow it, yes. But in AV fistula, pseudoaneurysm does not increase in size. And also we can see there is decrease in attenuation, while in the active bleeding there is maybe increased or there is constant, like hyperdensity. Yes, this is. We talked about we have lacerations, which was as an area of hypodensity, of area of contusion or hemorrhage, or we could get active bleedings or hemoperitoneum, like when you see a collection of low density fluid around the liver, and this area of devascularization. So let's.
So what do you think is more common, venous or arterial injuries in liver? Liver injury.
Venous.
Why?
Because the major blood supply provided by the venous. That's why. The more.
Okay, hepatic artery. So what's the difference? The vein has a very thin wall.
Yes.
While the artery has a muscular wall.
Yeah.
So it is more resistant to injury, the artery. Yes. While the vein is easily injured. Okay, which is a good thing because the vein has a low pressure, yes. So the bleeding is not.
Yes, it gives time to manage the case. Yes. So, of course, as we say, we have 5 grades: grade 1, grade 2, grade 3, and grade 4. Of course, this is increases in severity. So the grade 1, it's considered when we have subcapsular hematoma less than 10% of the liver surface, or when we have laceration that's less than 1 cm deep. Okay, we can see there's a defect in the parenchyma. This should be less than 1 cm in order to be like regarded as a grade 1, or if this is the whole surface area of the liver, if it was less than 10%, this is regarded as a grade 1 liver injury according to the AASC criteria. And also, so here, we see that there's a parenchymal defect. It's less than 1 cm, and associated with a small perihepatic hemorrhage is also seen. Arrowhead. Okay, this one. So what about grade 2? Grade 2, when the subcapsular hematoma, it involves 10 to 15% of the liver surface, or when we have intraparenchymal hematoma, which is less than 10 cm in size, or the laceration is 1 to up to 3 cm deep.
They are very important for everyone to memorize.
Even in our level?
Because, yes, sure.
Okay. So, we said that grade 2, when we have parenchymal defect up to 3 cm, 1 to 3 cm, or when you have intraparenchymal hematoma, it should be less than 10 cm, or the subcapsular hematoma, it involved from 10 to 50% of the liver area. You can appreciate that if this is a whole surface of the liver, of course, this is up to 50 or less than 50. So examples for that, we can see that there is a parenchymal defect or laceration. We can see this laceration is less than 3 cm, and also there's a collection of low density, which indicates that the hemorrhage, bleeding or hematoma. Another example for that, we have subcapsular hematoma, and we see the surface it should cover from 10 to 50% of the surface area of the liver, and it was proven to be such a subcapsular hematoma. It was also proven by operation on that case. So moving on to the grade 3, it's when we have subcapsular hematoma where more than 50% of the liver surface, or when we have a ruptured subcapsular or intraparenchymal hematoma, okay? Or when the laceration is more than 3 cm deep, any intraparenchymal vascular injury, whether it was pseudoaneurysm or IV fistula, so it's contained active bleeding, confined still in the liver.
So any vascular injury is grade 3, immediately.
Yes, but here it's confined. It's not
confined. As long as it's a vascular injury, we are grade 3 and above.
Yes. Not hemoperitoneum. Yes. Okay, so here it is liver surface, the subcapsular hematoma, it's involved more than 50% of the surface of the liver, intraparenchymal hematoma, or it could be a vascular injury, as the doctor said, either as an AV fistula or in the form of the pseudoaneurysm, or when we have the parenchymal depth, and the injury, the depth of the parenchymal laceration is more than 3 cm deep. These are all regarded as grade 3 according to the AASD guidelines. So here we can see the areas of hypodensity, and this involved more than 50% of the surface of the liver, if you can appreciate that this is the rim of the liver. And there's also an area of hyperdensity. This could indicate that there is active bleeding, attenuation foci within the hematoma. Okay, now we have another example for this grade, when grade 3. So when the laceration is more than 3 cm, you can see the area of hypodensity, and also there is an area of hyperdensity. This indicate active bleeding. These are all considered grade 3. So now we have grade 4. Grade 4, when the laceration involving 25 to 75% of one hepatic lobe. Okay, we didn't consider the whole surface area of the liver. Or when we have extraparenchymal extension, it's not confined to So we see active bleeding into the peritoneum. Look, there's active bleeding. It's demonstrated bleeding extending into the peritoneum. Or when we have this, hematoma or the liver damage, it's about 25 to 75% of the hepatic lobe disruption. So this is also an example of grade 4. We can see that areas of hypodensity and also active area of higher density or the active bleeding, and there's area of low density surrounding the whole liver. So in case that this bleeding has this extended to the subperitoneal space. So here's another example for grade 4. We can see there's parenchymal disruption it's shown by the areas of hypodensity, and it involved like 50 to 75 or 50, about 50% of the one entire lobe. So this is according to the AST guideline. Is considered
the right lobe is majorly involved, around 50 to 75%.
Yeah.
And there is evidence of intraparenchymal laceration and bleeding.
Yes, this
and
also
some blood in the peritoneum.
Yeah.
Right?
Yes. Okay, now the last grade is about grade 5. Of course, when you have the laceration destruction more than 75 of one hepatic lobe or injury to the major vessels, whether inferior vena cava or the central hepatic veins. So we can see that's area of the parenchymal damage or parenchymal disruption more than 75% of the hepatic lobe. Or when you have injury for the inferior vena cava or the major hepatic veins. We can see that there's a large area of hypodensity that's involving like the majority of the liver tissue, the entire right hepatic lobe.
It's completely damaged.
Yeah.
It's non-enhancing. It's irregular, and there's evidence of hemoperitoneum if you see on the spleen.
Yes.
Okay, and you have on the other image laceration extending all the way from the surface of the liver to the liver hilum.
Yes.
Okay.
So it's a very deep parenchymal defect. Yeah.
Since it's reaching the hilum, it's probably involving the vessels.
Yes.
Like the portal or the hepatic artery. So it will be.
Yes, and also we see that the major veins also has been like damaged. The left hepatic vein. There is no discontinuity of left hepatic vein because the areas of hypotension or the areas of I think the integrity of the vein have been disrupted. Right? It may show. Okay. So now, in summary, we have 5 grades according to the AST. So grade 1 when the regarding the parenchymal depth laceration, if it was less than 1 cm, it's grade 1. If it was up to 3 cm, it's grade 3. Okay, and you can correlate with the numbers. If it's in between, this is grade 2. About the subcapsular hematoma, if it was less than 10% of the surface area, this is grade 1. If it was more than 50% of the surface area, is grade 3. If it's in between 10% to 50, this is grade 2. Of course, we could have also intraparenchymal hematoma or like a vascular injury, but it's still contained within within the liver. Okay, and grade 4, when the no longer is contained in the bleeding, it has been extended into the peritoneum, or the disruption is about 25 to 75%. But in grade 5, the disruption is more than 75, or it could involve the major vessels, whether inferior vena cava or the hepatic phase. Okay, that's about the grading for the liver injury. Now, about the spleen. Before that, as a review, we can for the spleen anatomy. Of course, the location lies in the left hypochondrium region. It's closely related to the 9th and 10th and 11th ribs, and it's surrounded by the peritoneum, or say intraperitoneal organ, except at the hilum. We can see that it has two surfaces: the diaphragmatic surface, the visceral surface, where the visceral surface, where it contacts with the left kidney, with the stomach, with the tail of the pancreas, and so on. So if you look at the structure of the substance of the spleen or parenchyma of the spleen, of course, it has white pulp and red pulp. Okay, red pulp is just like a vascular lakes, yani sinusoidal spaces, and the white pulp just aggregates of lymphoid tissue. Okay, and also know that this helps the spleen to contain blood that can contain up to 1 liter of blood at any time. So imagine if you get injured, it will cause يعني volume, blood.
1 liter of blood to leak.
Yes. And of course, one of the reasons why it gets injuries easily because it has a thin fibroelastic capsule. Okay, so and also it's thin enough that cannot contain or handle lots of blood. It will get ruptured easily. So if you have like a subcapsular hematoma or so know that maybe after 1 week it will get and the patient will show signs of, let's say, hypovolemic shock or bleeding. So the area you detect, the better. So as we said, it contains red pulp and the white pulp. And so this will also explain why in the atrial phase of the CT scan, normally we see the spleen as these areas of, it's not homogeneous, it's inhomogeneous. It's just like a zebra or like tiger striped. This is because the time between the red pulp and the white pulp enhancement is different. First, the red pulp will get enhanced with the contrast media. Later on, the white pulp. Okay, so if you
only
see this
arterial phase, this appearance. Be careful. It's on the venous, it's homogeneously enhancing.
Yes.
So if it's in the arterial, you see this appearance. Only in the arterial. Arterial phase is how many seconds from injection?
Like within seconds.
How much?
To 15?
40 seconds, 50 seconds, 70 seconds?
15 minutes?
It's something between 15 to 30 seconds, something in that. Yes. Around 20-25. Okay? Seconds. From the moment of injection.
Yes. So this is again a normal artery enhancement. So be aware in order to not misinterpret as if there was an infection or infarction. This is quite normal. Quite normal in the arterial phase to see this inhomogeneous enhancement of the spleen. So let's go to our subject about the splenic trauma. Of course, we said the second most common is the liver, and first to that was the splenic trauma. Especially the blunt trauma due to the motor vehicle collision. And so this is the most common. It covers about 40% of all solid organ injury in the abdomen. It's related to splenic trauma. And what are the causes? It's either penetrating or penetrating trauma or iatrogenic, like, for example, secondary to colonoscopy. Or spontaneous rupture. Sometimes you could have either malaria or infectious mononucleosis or leukemia. So again, also when we have spleen injury, be aware about the neighboring organ injuries, either in the stomach or the pancreas or the colons or the left kidney, and obviously it's also closely related to the 9th and 10th, 11th ribs. So also most of the splenic injury could be also associated with the rib fracture. Okay, so left adrenal gland. So before going to the AAST criteria for the spleen injury, of course, again, the contrast enhanced CT scan is a modality of choice for detecting or for assessing the splenic trauma. And also, so the spleen, so normally should be spleen in the venous phase. You see, in the venous phase, it's like homogeneously enhanced, okay? Has a homogeneous density. But in the arterial phase, as we covered earlier on, it shows this inhomogeneous density, okay? So this might mislead you if that you could interpret as if there is laceration or injury or infarction. Okay, so we will do contrast enhanced CT scan in the portal venous phase, okay, for assessing the spleen injuries. Okay. So AST splenic injury scale, again, it was most recently revised in 2018, and it's very crucial for the diagnostic radiologist to know which assign the spleen injury to which grade, because this affects the management and management strategies, and of course, following up the case. So about CT features of the spleen trauma, it's the same. We could have a laceration, we could have a hematoma with a subcapsular or intra parenchymal. We could have an area of active bleeding. We could have an injuries to the vessels. We could have a pseudoaneurysm. We could have AV fistula. Just one thing that's different in the splenic injury that's not that we could rarely find in the hepatic injuries, that you could have also splenic infarction. And if we ask ourselves why is that, because we know that it has an enhanced blood supply, unlike the liver, which has a dual blood supply, so of course more likely to get infarcted. And
Liver has two blood cells.
yes, portal and hepatic.
If one is injured, the other will supply.
Compensating.
While the spleen has only the splenic artery.
Yes.
So if it's injured,
infarction.
Go into splenic infarction.
Yes.
There's no alternative.
Yes, and about how it's shown on the CT scan. According to the face, if it was hyperacute CT scan, we see that there is areas of mottled increased attenuation representing areas of hemorrhagic infarction, but it's hyperacute phase. So mostly we usually see as an area of pyramidal or triangular shaped hypodensity, okay, within the normal intervening enhanced splenic tissue. Of course, this is if the remaining of the spleen was normal. And also we have special cases, like if we could see also global splenic infarction if we get splenic torsion, like the main splenic artery, or we could have just infarction of the spleniculus, okay? So on the CT scan, we see area of pyramidal shaped in the periphery or wedge-shaped hypodensity. This will indicate that there's areas of splenic infarction. And this is important also to know this feature to distinguish from subcapsular hematoma. So if it was in the periphery or triangular, it's more likely infarction, not subcapsular hematoma. Subcapsular hematoma also appears at low density. So about the AST spleen injury grading system, of course, it's the same just like the liver. We have 5 grades, okay? And this the grades are increases in severity. So the grade 1, when the subcapsular hematoma was less than 10% of the spleen surface, or when we have a tear of splenic capsule or laceration that's less than 1 centimeter deep. So when the laceration is less than 1 centimeter depth, or when the surface area of subcapsular hematoma is less than 10%. Okay, you can see there is an area of subcapsular hematoma here. You can see areas of lacerations. This all categorized under grade 1. So then if we talk about grade 2, when you have subcapsular hematoma, 10 to 15% of the spleen surface, or when we have the intraparenchymal hematoma less than 5 cm in size, or when the laceration is 1 to 3 cm deep. So when the laceration is up to 3 cm depth, or when the intraparenchymal hematoma, of course, less than 5 cm, or subcapsular hematoma, that is about 10 to 15% of the surface area. We can see area of hypodensity. This indicates a subcapsular hematoma. And it's also area of laceration, also up to 3 cm, and areas of hypodensity, which is subcapsular hematoma, about 10 to 15% of the surface area. Now about grade 3, when the subcapsular hematoma was more than 15% of the spleen surface, 15, yes, sorry, or when you have a ruptured hematoma, whether it was subcapsular or intraparenchymal hematoma, or the laceration, it's more than 3 cm deep. So this is grade 3, laceration more than 3 cm deep, when the intraparenchymal hematoma was more than 5 cm, or the subcapsular hematoma more than 50% surface area. Okay, this area, you can see that there is an area of hypodensity that involved more than I think this is the hematoma, right? Subcapsular intraparenchymal.
Hematoma with deep splenic laceration.
Yes.
More than 3 centimeters. indicating grade 3 injury.
Grade 3, yes. Now, grade 4, when we have an intraparenchymal vascular injury, whether it's pseudoaneurysm or AV fistula or contained active bleeding, so it means not hemoperitoneum, or that when the laceration involving the central splenic vessels that resulting more than 25% devascularization of spleen tissue. Grade 4, when we have confined active intraparenchymal bleeding, or when the area devascularizations that more than, it's up to 75, so it's 25 to 75%. Of course, we have vascular injury, either as an AV fistula or pseudoaneurysm. So this image, I think this area, we can say this an altered enhancement, right? So
complete devascularization here, right?
Yeah, complete.
The whole spleen is devascularized,
yeah.
and there's some intraparenchymal contained bleeding. This the hyperdense part of
Indicate that there's vascular injury.
yeah.
Okay.
Vascular.
Now remember, this still confined to the spleen, and not hemoperitoneum. In grade 5, we have extraparenchymal extension of active bleeding into the peritoneum, or simply when we have shattered spleen. Okay, when you have shattered spleen, look, there's multiple lacerations across the spleen, or when we have the bleeding was extended beyond the splenic organ and beyond into the peritoneum. You can see this area of I think this is
the whole spleen is shattered. It's into multiple little pieces.
Yes.
You cannot see like a proper spleen anymore. And there's bleeding, of course, some free fluid in the region of the splenic bed.
Yes. This is, I think, hemoperitoneum, right?
No.
Okay. Okay. Yes, this is same. We can see
multiple pieces of spleen here and there.
Yes, shattered spleen. So this is regarded as the most severe one, which is grade 5, according to the ASD criteria. So, so briefly, we have 5 grades again for the ASD criteria for the spleen injury. Grade 1, when the parenchymal defect less than 1 cm. Grade 3, when it is more than 3 cm. In between is grade 2, 1 to 3 cm. Or when the subcapsular hematoma less than 10% is grade 1. But if it was more than 50% of the surface area, it's grade 3. In between, it's grade 2. Or we could have also like ruptured or intraparenchymal hematoma. Here in grade 4, we have vascular injury, whether it's in the form of pseudoaneurysm or AV fistula, an area of devascularization that's up to 75, okay? It's grade 4. But more than that, or shattered spleen or hemoperitoneum, it's regarded as grade 5. So let's see examples about the splenic injuries. We can see these areas of hypodensity, like across, like most of the spleen injuries, got damage. So this is shattered spleen grade 5. And in the coronal section, again, we can see that there is areas.
It's not enhancing properly. You
Yes.
cannot even see a proper spleen. It's just multiple little tiny pieces with a large amount of intra-abdominal fluid around the liver and around the spleen. That's a big hemoperitoneum. So this is a
grade 5.
Shattered there. Really yes. Shattered spleen.
Yeah, and if this spot of hyperdensity is indicated, there is active bleeding. Yes. So here we can see this area of devascularization, or let's say hypodensity, which was
not devascularization.
Yeah,
hematoma.
Sorry. Yes, hematoma.
It has a mass effect. You can see the spleen under it. It's compressed.
Yes.
Because it has a big mass effect. It's a large hematoma, but it's not infarction, not splenic.
Yes, sorry. This is a large subcapsular hematoma, and involved. We said it has to be involved more than 50% of the surface area of the spleen in order to be regarded as a grade 3. And here again, we can see that shutter spleen. We can see that like the integrity of spleen like completely changed, destroyed. Or this is also regarded as grade 5. We can see area of laceration, that's less than 10%. So the areas of subcapsular hematoma, subcapsular. See, can you see this laceration? Yeah. It's a linear hypodensity. Yeah. Tiny laceration. Yeah. Yes, this is regarded as grade 1 injury. And of course, area of hypodensity. Again, this is the as a subcapsular hematoma. Yes. Yes, unlike hemoperitoneum. Yeah. Because hemoperitoneum just goes with the rim of the spleen without causing pressure on the underlying the spleen. Yes. Well, here is contained. Okay, here we can see areas of lacerations that involving more than 3 cm. This is, up to 3 cm, less than 3 cm. Because more than 3 cm is grade 3. This is regarded as grade 2. Yeah. And also we can see areas of hypodensity and which is complex lower lobe splenic laceration. So these figures are all bad quality, but I extracted from like Medscape, from radio.
You know why it's bad quality?
Yes.
Because these patients are irritable. And they are not cooperative. They are breathing, they are moving, they are in pain. So there's a lot of motion artifacts. So it's not the image, it's the patient.
Okay, yes, that's a good reason. We can see that there is a fractured spleen involving more than 25%, and we can also areas of hyperdensity. This could imply that there is active bleeding. This was regarded as grade 4 splenic laceration. And also this other grade 4 splenic laceration, area of hypodensity, multiple. And we said, also, can you see this vascularization? Area of devascularization?
Devascularization and bleeding with hematoma.
With hematoma. And this is also trauma. Spleen, we can see that there is area of any. Yes, like the place where the spleen sits. We can see there's just like yes, hematoma, big hematoma, and there's also contrast, dense contrast collection in the splenic hilum. This one, okay.
So this is grade
5. Yes, because the major. Yeah. So this is the laceration that's involving more than 3 cm. This was regarded as grade 3, okay, hypodensity area, and also. Sometimes we see a big hypodense area, and in the place of the spleen where it sits, and this is actually the sequelae of subcapsular hematoma, chronic subcapsular hematoma, and we can also regard this as a pseudocyst, right?
If it's causing mass effect on the spleen, it's with history of trauma. It's chronic hematoma. It's not subacute or acute because it has a fluid density. It's not like the acute or subacute should be more dense than that.
Yes.
Pure fluid density is chronic.
Yes, this was also the case of chronic subcapsular splenic hematoma.
Pseudocyst will not cause mass effect on the spleen. Maybe on the pancreas, but not on the spleen.
Okay. So if you hear about the post-traumatic splenic pseudocyst, like this will define it. Let's say, we'll circumscribe it, fluid density lesion. This was the sequelae of splenic trauma, and also
it's a subcapsular, chronic. It's a chronic hematoma.
Chronic hematoma.
They just change it to a cyst.
It's like evolution of chronic hematoma to pseudocyst. Of course, not all patients are hemodynamically stable, or let's say not in all settings. Ultrasound and the CT scan, contrast enhanced CT scan is accessible. So, ultrasound has a major role for detecting splenic and liver injuries. And we have a EFAS scan, which is the which its aim is to specifically in trauma settings to identify if there is any intraperitoneal free fluid, uh, uh, because this would imply that there is underlying solid organ injury. So it's not necessary to detect the solid organ injury. But when we find that there is a free fluid, this will guide us to transfer the patients to either to the, if it was unstable, laparotomy, or to the CT scan or follow up. So ultrasound has plays a major role. So IFA scan, we have, as we know, it covers 5 areas. In the second intercostal space, we look for the pneumothorax, and in the cardiac region of subxiphoid, we look for the pericardial effusion. In the right upper quadrant, which is our subject, and left upper quadrant, is to look for fluid in the Morrison pouch or in the below the diaphragm, if there's any fluids, or in the paracolligator. In the left upper quadrant or flank region, we can look see if there's fluid between the spleen or between the kidney or around the spleen. And in the last one is the pelvic region, in the Douglas pouch in the female, if there is free fluid, or in the male's rectovesical pouch. So in the right upper quadrant, if you place a probe, here we can see normally we have a pouch, it should appear like that, between the liver and the right kidney, if there is no free fluid, and it should be the space should be completely obliterated, right? Between the spleen and left kidney as well, we have a space, so we look also in the perisplenic space to look for the splenic injury. So we can see that there is area of anechoic area. This is indicate that there is a free fluid between the left lobe of the liver and the right kidney. So of course this implies that there is indeed
So if you see that, there's
yes,
indication for CT scan.
Yes, or there's a liver injury.
Just go for CT.
Yes. Again, this is a free fluid between the liver and between the kidney. This will denote that there is underlying liver damage. Or between the spleen and the left kidney, we can see that there is a free fluid around it. Again, there's a free fluid between the spleen, and this is the diaphragm, right? And it also helps us to, if there's any pleural effusion or there's fluid in the paracolligator, we have to assess that in all the patients, traumatic patients. Again, we have this patient who was a history of blunt trauma to the abdomen, and when we do the ultrasound, we realized, we found out that there is a free fluid between the liver, anechoic area free fluid, and the right kidney, so in the Morrison pouch, and also at the other side, in between the left kidney and between the spleen, we can see that there is a fluid around it. Okay, normally we shouldn't see this free fluids. Again, another picture, we see that there's a free fluid in the between the liver and between the spleen. This denotes that there is underlying liver damage. Okay, and this is above, let's say, between the spleen and between the diaphragm. Right, there is a perisplenic area, fluid collection. Even there is a damage to the splenic ecotexture.
Subcapsular hematoma, and you can see inside the pleural effusion.
Yes. These hepatic lacerations, we can see the area of anechoic or hypoechoic, and the disruption of the ecotexture of the liver. This will we can regard this as a linear shape. This shows that there is a laceration, and it's a parenchymal defect. Yes. Again, it's a parenchymal defect. This indicates that there is a liver laceration. Splenic laceration, we can see that there is an area of hypoechoic, or let's say there's a disruption of the splenic ecotexture. This we can write that there is a splenic laceration. It's also not normal, right, doctor?
This is just some
maybe high level
subcapsular or possibly fluid.
Yes. We can see area of hyperechoic area in the liver. This was in a 70-year-old kid with abdominal trauma.
That can be interpreted as a hemangioma or
Yes.
as a or as a contusion.
Contusion, yeah. And of course, it also, I think, depends on the time of the study.
And the history.
Like, to be, if it was chronic, it will be hypoechoic. Sure. Yes, this is hyperechoic because acute setting. Now, splenic contusion, we can see that's area of echo-poor rich parenchymal region, shows echo-poor, hypoechoic area, yes. It's not like the rest of the spleen. This indicates that there's splenic contusion. So about subcapsular hematoma, of course, this is depends on the age of the hematoma. If it was it will high echogenic or hyperechoic in the acute setting, but in the chronic phase, we can see the area of hypoechoic. This 1 month later.
Like the city. In the acute stage, it's dense, and then it becomes hypodense.
Yes.
So it's in the acute stage, it's hyperechoic, and then it becomes hypoechoic.
Yes. Of course, those hematomas are lenticular shaped, or like there's a collection. It's unlike the laceration. It's not like linear pattern or.
No, it's just lentiform and causing mass effect on the surface of the liver.
Yes. So about the intraparenchymal hematoma, we see that this area of this ill-defined area of the mixed echogenicity, right? There's hyperechoic and also hypoechoic. So this means that there's disruption of the liver parenchyma. And 2 days later also shows the same, but in chronic phase we see it will be more hypoechoic because of the progressive liquefaction. Splenic hematoma, we can see that's area of hypoechoic region, and there's also another one. This is subcapsular hematoma, but this is intraparenchymal hematoma. Again, we see that there is a area of like echo-poor region in the
splenic region.
Yeah. Okay. Yes, and also there is a free fluid between the, or let's say, can we say the subcapsular hematoma also, or just free fluid, or we cannot rule it out?
Well, I would say this is free fluid.
Free fluid. Yeah. Okay. Yes, between this will all guide us that to further follow up the patient for the splenic injury. So we, as we talked about, we could have infarction in the spleen because it has an arterial blood supply, and when we see infarction on the ultrasound, it appears as a, of course, classical should appear as a pear-shaped, pyramidal shape in the periphery, hypoechoic area, but we could have also mixed heterogeneity. Or mixed or heterogeneous echogenicity, sorry. This will could indicate that there is a liver, spleen infarction. And also there is a sign which is called bright band sign. This can be
bright sign because you can see these bright lines within the hypoechoic spleen, indicating this is an infarcted part of the spleen. And if you put color Doppler, you will not see flow in these parts because there is splenic infarction.
Okay, now a biloma. Of course, when there's injury to the bile ducts, let's say biliary tree, we could have a collection of hypoechoic area, and this was because of the contained bile within the liver tissue. Okay, it's well-defined fluid collection. Okay. Now, another study, we have angiography for assessment of the liver and splenic injury, and this plays a big role. So angiography, this is has a therapeutic role and also has a diagnostic role in order to find the injuries. Because by the angiography we can like do embolizations or stenting for the AV fistula, and this also, for example, if you have a patient that's hemodynamically stable and we still want to keep it like in the ward or the RC or ICU, but in order to decrease the blood the reduced transfusion requirement, for example, receive, let's say, 4 pints, and in order to decrease that, we can treat it by this angiography. And here we will not do laparotomy because it's not severe enough. We just kept it on like follow-up. But if you do angiography, and this plays a role here for treating the vascular.
The vascular compromise, if there's anything bleeding, then you can go by a catheter into the splenic artery or into the hepatic artery and just embolize this artery to keep blood loss to a minimum.
Yes, and also has another role. If you want to distinguish between AV fistula and pseudoaneurysm, this can be only done by the arteriography, not by CT scan. Okay, here we can see there is like a punctate, like a spotted appearance of this. This is spleen, by the way. These are all indicate that there is extravasation of the contrast, and so okay, there's a parenchymal injury. Yeah,
tiny pseudoaneurysms.
Yes, and this has a term, Surratt spleen. Surratt, yeah. So this is a typical feature that only can be found by angiography study. So this was a right hepatic artery. We can see the area of collection of blood with pseudoaneurysm as a sequelae of trauma. So we can treat it by the angiography, either by the stenting or by the embolization. We can see here now has been diminished, the collection. Or for the splenic pseudoaneurysm, again, we can see that this area of here, right? You can see there's collection of contrast media, and it can be so this indicates that there is a bleeder here. By
coils.
Yeah, coils. We can
causing complete obstruction.
Yes.
Of the artery.
Again, we can see that there is a collection of contrast media, indicates that there is a vascular compromise. So, if we put embolic coils, we can treat the case, and this will, by the blood transfusion, I mean that this will, therapeutically,
they do put coils inside the artery. The artery will be closed, and the bleeding will stop.
Yes. Okay, now the last slide. Hepatic scintigraphy. This is done only for the bile leak, or they say biliary tree injury. We use technetium 99M, and so if we are looking for if there is a contained bile leak, like biloma, as we mentioned, the ultrasound picture, or if there is intraperitoneal bile leak. Okay, this will if there was a if the collection of course, the radiotracer and it collects in an area, if it was remained stable, and size-wise was remained stable, in case that it's confined, this is biloma. But if it was increased in the size, that means that there is will demonstrate that there is extraluminal collection, the pattern that varies or increases in time.
So they inject the contrast, the radiotracer, not the contrast, and they will wait. If the contrast is seen if the radioactive substance is seen collecting in the side, the liver, in a specific side, then this is bile leak. If it's not, there is no bile leak.
Yes.
Because there are some radiotracers that are excreted just by with the bile.
Yes.
By the liver with the bile. It's not by artery, not by the.
Yes. Thank you.
Thank you very much. Amazing.